My name is Brian Hansen. I'm with the California Department of Healthcare Services. I'll step a little closer to this. Can you hear me okay? Good. And primarily I work on policy development for specific programs, usually programs that are redesigning how we pay for our Medicaid services and how we do those services for people who are generally in a high-risk category, who need a lot of services. And so I want to thank you all for the opportunity to talk about this great program. It's been one of the most exciting programs I've worked on in 11, 12 years with Medi-Cal. So what is this program about? I heard an anecdote, a true anecdote, about an individual, a Medicaid person, who went to the emergency department 330 times in 1 year. And that obviously is an extreme example, but that type of situation is what this program is designed to focus on. It is for folks a little bit different from some of the other prevention type concepts that we're talking about, but this is for folks who are experiencing challenges with multiple social determinants of health, medical care, chronic conditions, substance use disorder issues, behavioral health conditions, housing conditions, jail reentry issues, and often 3, 4, 5 of those things all at one time. And so what that ends up creating is a situation where that person has a great deal of difficulty negotiating any of our systems because our healthcare system was not designed around that person. It was designed for a different, maybe a middle class, upper middle class type of person, and getting this person a primary care doctor's appointment and calling it a day is not going to solve that issue. So our whole person care pilot folks got together and they decided, look, I think we can do something for these folks, but we have to go after all of those issues at the same time in a coordinated approach in conjunction with talking to that individual about what it is they want and what it is they think they need. So I'll talk a little bit about that. The funding, the other thing is that type of individual impacts our systems, our state-funded systems and services, the federally funded services, and county-funded services, and they are the people you see at these places. So if your emergency department is overcrowded, if your emergency services ambulances are having trouble keeping up with demand, and if your Medicaid budgets are high, all of us, federal, state, and local counties have a distinct interest in, from a budget perspective, of trying to figure out a way to help these folks and keep them away from services that are avoidable, that are not positive, and that we should be able to keep folks out of. So what we have is an 1115 waiver mechanism in Medicaid that allows us to demonstrate to the federal government that our Medi-Cal program is creating efficiencies, and in our case, it's through our managed care program that is saving the federal government money. And then the federal government allows us to make a proposal to them to spend some of that savings on programs that we all think would be a good idea. This is one of those programs. State budgets being tight, as they always are with general funding, we looked around for a solution where the federal funds provide half the funding in this type of mechanism, the 1115 waiver. So we needed the non-federal share, 50% matching funding. And counties decided that, yeah, if we could put together a program and get that funding, they would put up the matching funding because they have a lot to gain from this type of program as well. So that's how the funding came about. So what this program does is it provides $3 billion over 5 years for local counties to design and propose pilot programs to impact frequent utilizers of services in their areas. And the idea is that each of those pilots is different, and that the county will go through a process where they do data analysis, they talk to stakeholders, they figure out, okay, what are the particular problems that are inhibiting better management of these high-risk populations in our particular county. They do that, Then they come up with the solutions based on that analysis. They put it in their application, give it to us. We look at it, see that, oh yeah, that tracks, it makes sense, and then we approve it. And so what we have then are, right now we have 18 approved pilot programs. We have a second round that we're going to be, we're reviewing right now. We'll have announcements on approvals in a month or a month and a half or so. So at least 18, up to maybe 25 different counties will have these programs. And each county is taking a different approach. It gives us an opportunity, a very well-funded opportunity to study 18 or 25 different approaches, different sets of strategies to solve these problems. And primarily what the funding goes for, and the state set out, the state and the federal government came up with the broad parameters of what was allowed under this program, but there is just lots of flexibility within that broad framework. And we really wanted to err on the side of providing more flexibility. So we left the rules pretty wide open. And then when we got an application that had something we or the federal government thought we couldn't quite do, then we pulled it back. But we started with this idea of let's be as flexible as we can. So we have all of these different incubators and experiments. They're going to be very well funded, very well evaluated, and we will look at all these different strategies and have a great source of information about what creative strategies work for this type of population. And most of those strategies will go towards things that we've all heard about. Integrating the various silos. So we have, behavioral health entities within the county, jail, public hospitals, emergency rooms, the Medi-Cal managed care plan, county public health department, homeless supportive services providers, other community-based providers in the county, all of them coming together to do this through these pilots. Okay, and then once we get into this program and start getting information about what appears to be successful, both from improving health outcomes, improving life for these folks, and cost effectiveness will be something we'll be studying as well. Then that will lead to a discussion about sustainability for the future. This is a 5-year program. It's a lot of funding, but it's time limited. So we want to get all the information that will lead to that sustainability discussion in the future. So I wanted to give that broad context before I got into the slides. The slides have a lot of nuts and bolts about what this is, but I thought kind of where we started from, where we came from was good to start with. So overarching goals, some of the things I talked about: coordinating health, behavioral health, social services, a whole person approach, which is something we've heard. This is a real effort at getting that done. Identifying target populations, sharing data between systems. It started with the application process, with these entities coming together and sharing data between your local jail about recidivism with your county public health department, and kind of those overlapping circles to try to identify the population that they could all work on together. Goals and strategies: integration among county agencies and our Medi-Cal managed care plans, coordination, access to housing and supportive services, health outcomes, data collection, and infrastructure, reducing inappropriate emergency department, inappropriate, avoidable inpatient ED use. That's something Medi-Cal looks at and the federal government, because that's what we pay for. Counties have lots of things that they pay for that they're very interested in reducing that I've mentioned. By the numbers, so there it is. The $1.5 billion is the federal funding. It's matched by another $1.5 billion by each local county for their own pilot. No single pilot gets more than 30%. Essentially, that's the Los Angeles County rule. They got 30% in their first round application, so, and we're seeing what's happening in round 2. Funding is based on semi-annual reporting of activities and interventions. The non-federal share is provided via intergovernmental transfer. Essentially, that's a Medicaid function whereby a local organization, public organization that takes in tax revenue, can transfer funding to the state Medicaid agency to use as the non-federal share. So these local counties are putting up their matching funds through that mechanism. The lead entities, this is different from what we normally do in Medi-Cal, or what I normally do, which is operate through our Medi-Cal managed care programs. We're implementing a health home program, and that's how that's being done. We carve it in as a managed care benefit, and then we work with our managed care plans, and they run it. This is very different because it's led by and run by the local county organizations direct. And then participating entities, this really drives home sort of the requirements of cross-silo coordination from the beginning in their analysis, their application, et cetera. So we've got a Medi-Cal managed care health plan, the Health Services Agency, Specialty Mental Health Agency, one each in each county, and 2 community partners required at least. And they all collaborate together and have a plan for coordination in their application. Relationships between the entities. One of the main goals and one of the main funding availabilities is to assist with policies and infrastructure to develop this coordination between these entities, whether it is administrative policies, meetings, staff to do these types of things and work together, or data systems development so that they can share information between each other. So there's some requirements about what the lead entities have to do to bring this all together. Target populations. So this, I mentioned the 330 ED visits. This is a collection of criteria that a number of experts came together and decided was generally the type of population that resulted in that frequent utilization. It is not, our applications are not limited to this, but this gives you an idea of generally where we're focused with the Medicaid population. I will mention that this is for Medicaid eligible folks. And one other aspect is this provides funding for things Medi-Cal will not pay for. So it's additional money on top of what Medi-Cal funded services, and this all has, the application has to demonstrate how the services provided through the pilot are going to kind of supplement, wrap around, support regular Medi-Cal services for behavioral health, medical health, or other social services. So what you will see, again, it's fascinating to see some of the innovative approaches they have taken. And so, you know, you get this concept, some things we've heard about a lot, is housing sometimes the best thing to impact healthcare and health, or is healthcare sometimes the best thing to help with jail recidivism? And this is an experiment to help with those kinds of things. Program structure. So it is broken into a number of budget categories. It gives you an idea of the types of things that can be funded. Administrative infrastructure I just talked about a little bit. Delivery infrastructure is similar, but it's more kind of foundational infrastructure to support the delivery of services. And you'll see a few examples there of things that we will pay for. Payment mechanisms for actual services. These are a couple other budget categories that we can include in the application. A PMPM bundle, which would be, it would operate similar to a capitation payment, but it is for a specific bundle of services, like a care coordination bundle that may include outreach, mobile outreach for a homeless population, wherever they are on the street, in addition to a case manager who is doing that whole person assessment of needs, developing a care plan, interacting with that person's other providers and other service providers, and ensuring this is all coordinated and that that plan gets carried out. And fee-for-service items, we will also, people can structure their payments in fee-for-service as well. We also fund incentives. So with this PMPM bundle, there is an emphasis, we talked about value-based purchasing, value-based payment. I heard that mentioned earlier in one of the talks. We, with this program, are gradually trying to move, the system towards value-based purchasing, and there are incentives for doing a per member per month, which puts the organizations who maybe are more used to dealing with cost-based reimbursement, gets them more familiar with a situation where they're responsible for a package of services and they get a set amount of payment each month and have to sort of manage that. And so there are also incentives that are based on achieving certain performance metric outcomes. We will pay for achieving things like reducing inpatient days on the aggregate, or reducing ED days, or getting a program up and running within a certain amount of time. Again, the whole budget is designed to pay. It's not quite like a grant where people develop a broad structure and we hand over a pile of money. And it's also not a cost-based reimbursement program where they just give us an invoice for what they spent and we reimburse them for that. It's somewhere in the middle. They develop the structure of the budget up front, and then they get paid when they complete deliverables. So a per member per month bundle, they will develop the per member per month bundle first, and then they will send us an invoice that tells us how many people they successfully enrolled and are delivering services to, and we will pay based on how many people they successfully enrolled. So it really incentivizes actually, these programs are very transformational. It's a big lift to try to make some of the changes and get this up and running. It's a very short turnaround time, as it often is with Medi-Cal and Medicaid. But there are a lot of incentives built into the system to fund kind of moving fast, getting people in, getting them services. Performance measures. Definitely CMS and the state and everybody were very interested in making sure we're tracking the right performance measures so that when we get to the end of this, we've spent all this money, we've delivered all these great services, we can know what effect it had. All pilots have to report initial baseline data on their populations so that we can then ongoing data about what's happening with the population as we move forward, so we can track it. Specific performance measures are listed here. They're probably ones that you would all recognize, relating to good health management of chronic diseases, avoiding things that are avoidable, et cetera. The summary of the first round applications are listed here. So you can see which counties we're operating in now. Again, we have a second round of applications that we're reviewing right now. We'll have information on that out soon. Los Angeles, you can see, is projected to serve over 100,000 people through this program. So, I mean, it's fun. The scale of things we get to work on in California with Medi-Cal and Medicaid is just great and always makes me smile. So, it's wonderful. Target populations. So here's some statistics. I wouldn't pay too much attention to how many pilots are doing each of these things. Those statistics aren't necessarily totally accurate. But these categories give you an idea of the types of target populations, the coordination strategies that are being used in the pilot, data and information sharing. So this is the nuts and bolts of what these pilots are doing to get this done. Services and interventions. I will mention regarding housing services, just because I think it's a good example. We have pushed the envelope with this program as far as we could regarding what a Medicaid-funded program will provide for housing services. We will not only provide tenancy, case management services where they're helping people find housing. We'll also fund things where case managers are helping them keep that housing, coaching them, working with them and their tenants. And it will even fund one-time startup things if they need some modifications to the house or to help them with their first month's rent. It will not fund actual housing, which is a red line that CMS has drawn with Medicaid-funded programs, but it provides a lot of funding that local programs who maybe are providing some of these services right now with other pots of money, they can now shift that funding over to whatever housing pool they have to fund actual housing. And a lot of the applications have strategies built in where they talk about how they're going to do that. So this is some information about the round 2 applications. If anybody's interested, you can look at some of this material about what the application looks like. I will say our last slide has our website on it. If you just Google DHCS Whole Person Care Program, it will come right up. And if you want to look at the actual applications in detail, they are PDF'd. They are on our website for each of the county pilots that we've approved so far. I might recommend Los Angeles if you want to look at one. It's very big, but it's very, I think, well done and a good example of very broad, many target populations, many different strategies that they are very ambitious. So the round one pilots began January 1st, 2017. And the round two pilots began operation July 1st, 2017. We are entertaining new pilots applications as well as expansions of first round pilots. So some of the first round folks may grow their programs a little bit. In review of those applications, I want to specifically thank the Department of Public Health and the Department of Housing Community Development, who helped us review the applications with their specific knowledge about things that are happening in these local counties. And it was a great assistance for us. And there it is. So I think I'm just about out of time, but I will give one quick example. So Los Angeles County, what they are doing, they brought together already 42 different organizations. They are operating this program throughout Los Angeles County in their 8 regional areas that they have. They have enhancements for data sharing that they are funding. They have administrative infrastructure that they are funding to bring these organizations together for meetings, policies, governance, etc. They have 5 distinct target populations, including homeless folks, huge populations that they hope to serve in this program, jail reentry, and folks with chronic conditions who are frequent utilizers. And they have distinct bundles of services for each of those populations. For example, for folks who are homeless, who need supportive housing services, they have a care coordination bundle. They provide what is called respite services or recuperative care, which allows a homeless person who's coming out of an acute care situation to have up to 90 days in a place where they can stay, where there is some level of medical monitoring so that they can recover, don't have to try to recover on the street, which often ends up with them back in acute care. They pay for sobering centers, which offers up to 24 hours for folks who are inebriated publicly to recover in a safe space instead of going to jail or to the emergency department. And that's just a sampling of some of the innovative strategies they have. And that, I think, is what I will leave you with. And again, thank you so much.